Have you ever thought about how the body manages to hold urine for hours and then suddenly release it at just the right moment? It's a complex and finely tuned system involving the bladder, brain, spinal cord, and muscles working together like a perfect orchestra. When any part of this system goes off beat, urinary incontinence develops. Let's explore the pathophysiology of urinary incontinence step by step in an engaging, practical, and deeply clinical way. Normally, the bladder acts as a storage organ. Its muscular wall, called the detrusor muscle, stays relaxed while urine gradually fills inside. The internal urethral sphincter at the bladder neck and the external urethral sphincter, controlled by voluntary muscles, remain closed to prevent leakage. Sensory signals from the bladder wall continuously travel through the pelvic nerves to the spinal cord and brain, letting the body know how full the bladder is. When the bladder reaches a certain volume, brain's pontine micturition center and cerebral cortex coordinate the decision to urinate. Once the brain gives permission, the detrusor muscle contracts, the sphincter relaxes, and urine passes out. But in urinary incontinence, this coordinated system breaks down due to muscle weakness, nerve damage, or structural abnormalities. Let's look at each type of incontinence to understand the mechanisms behind it. In stress incontinence, the problem lies in the pelvic floor muscles and urethral sphincter. Normally, they resist increased abdominal pressure. But when these muscles weaken due to childbirth, obesity, menopause, or surgery, even small increases in pressure from coughing, laughing, or lifting can push urine out. A simple mnemonic to remember is STRESS, sphincter weakness. Trauma from childbirth, reduced estrogen, excess pressure from obesity, surgery effects, and sneeze or cough triggers. Nurses should remember that pelvic muscle rehabilitation and Kegel exercises are key interventions for this type. In urge incontinence, the detrusor muscle becomes hyperactive, contracting without the brain's consent. This leads to a sudden and intense urge to urinate, often followed by leakage. The cause can be nerve dysfunction from stroke, multiple sclerosis, spinal injury, or bladder irritation from infection or stones. Think of the bladder as a rebellious muscle firing too early. A quick tip to remember is U4 uncontrolled contractions in urge incontinence. The underlying mechanism is a loss of inhibitory signals from the brain to the bladder, meaning the bladder acts before permission is granted. Next, in overflow incontinence, the bladder becomes overly full but cannot empty properly. This happens when there is outlet obstruction, as in benign prostatic hyperplasia in men, or when the detrusor muscle becomes too weak due to diabetic neuropathy or spinal cord lesions. Imagine the bladder as a balloon that S overinflated and can T-release air efficiently, simply leaks slowly under pressure. The key pathophysiological point here is increased residual urine volume and decreased bladder contractility. The mnemonic OVERFLOW, obstruction, volume retention, enlarged prostate, retention, overflow, full bladder, low detrusor tone, outflow blockage, weak contractions helps recall the major causes. Then comes functional incontinence, where the urinary system may be perfectly normal, but physical or cognitive impairments make it difficult for the person to reach the toilet on time. This is commonly seen in patients with Alzheimer's disease, arthritis, or severe immobility. The brain-bladder connection remains intact, but environmental or physical barriers cause the problem. Nurses should focus on toileting schedules, accessibility, and mobility support in such cases. Sometimes, patients experience mixed incontinence, where both stress and urge mechanisms coexist. This is particularly common in elderly women, making management more complex. It's important to assess which component is dominant to plan appropriate treatment. A special consideration is neurogenic bladder, a condition caused by disruption in the nerves controlling bladder function, often seen in spinal cord injuries or multiple sclerosis. Depending on the lesion site, the bladder may be spastic hyperreflexic, leading to urge incontinence, or flaccid areflexic, resulting in overflow retention. Understanding this distinction is vital because treatment very spastic bladder requires relaxation strategies, while flaccid bladder needs emptying assistance like intermittent catheterization. Key physiological points to remember. Parasympathetic nerves, S2S, for stimulate bladder contraction. Sympathetic nerves, T11L2, maintain bladder relaxation and sphincter tightening during filling. Somatic control from the pudendal nerve allows voluntary control of urination. Any disruption in these pathways can result in incontinence. From a nursing perspective, pathophysiology knowledge helps in identifying the root cause. For instance, if leakage happens on exertion, it indicates sphincter weakness stress type. If it follows urgency, it's bladder overactivity urge type. If it involves continuous dribbling, it's likely overflow retention. Recognizing these patterns ensures accurate diagnosis and targeted care. A quick clinical tip: always correlate symptoms with timing, frequency, triggers, and volume of leakage. Encourage patients to maintain a bladder diary to identify patterns. This not only aids diagnosis, but also improves patient involvement in their own care. In conclusion, urinary incontinence is not a single disease, but a result of disrupted harmony between the bladder, brain, and sphincter mechanisms. Whether due to weakened muscles, nerve dysfunction, or obstruction, the underlying pathophysiology reveals the direction of management. For nurses and medical professionals, understanding these mechanisms is crucial for designing effective care plans that restore not just bladder control, but the patient's confidence and dignity.